We have a great group of physicians who are all board certified, practice the specialty, mostly by evidence-based protocols. We're not going to gain a lot at this point by trying to finesse medical care within a certain specialty area that's already very good. The real issues we have are exactly the things that Dr. Orenes and his committee are dealing with Eleanor, is the transition to care, how the communications occur. As we all know, that's where really there's a lot of opportunity to improve care and improve outcomes. A big part of that is work that's being done in parallel to DHP. That's the work we're doing through the Delaware Valley ACO, which is a medical shared savings program for Medicare traditional lives attributed to the primary care docs in our community. Dr. Paul Spiro has taken on a very heroic job of being the medical director for our pod for the Delaware Valley ACO, and a lot of work they're doing there, working with the primary docs to improve care and improve coordination, is clearly going to very quickly migrate into DHP. So I thought it was only very important for Paul to make a couple of comments.
Al, thanks for warming up the crowd. I really appreciate that. So the Delaware Valley Accountable Care Organization began doing under a Medicare shared savings program in January 2014 with physicians groups from Jefferson and Mainline Health and Holy Redeemer. And just January this year, Doylestown physician groups entered with an additional 9,000 Medicare patients, bringing the total number of Medicare patients in the ACO over 60,000, making it one of the largest ACOs in the country. This is not a DHP contract, but it is a contract involving the hospital and almost all of the adult primary care practices, and it's one that really is going to allow some learning and help drive change. The requirements of all the primary care practices are significant and really will get us going on things. We all have to have a certified electronic medical record and use them and be certified and attest as meaningful users. In order to actually make it meaningful, we're having 10 quality metrics that we have to be reporting on a quarterly basis. And these are things like cancer screening and counseling for smoking cessation and weight, looking at managing chronic diseases such as diabetes and hypertension. And these are not just push-button things. We have to really work at engineering workflows in the practices to make the data end up in the right field so the actual report is meaningful. A lot of work to be done. The patient-centered medical home recognition is a requirement, at least moving towards it and submitting by the end of 2016. Now, more than half the practices are already patient-centered medical homes, excuse me. But the rest are going to have to work towards it, and the ACO is providing materials and education and help, and we're all going to need it. And those of us who already have certified are really not far from recertifying. It's a 3-year process, and this brings together all sorts of aspects of transformation of a practice in terms of how we communicate with patients and each other, how we look at the population and manage the data, and how we are patient-centered and really look at what our patients want. In order to do that, we're going to learn more about what our patients are experiencing, and a patient experience survey is going to be performed on a sample of our patients after they've seen us. This is something very new for primary care doctors. We've really not had this type of information before. It's a little bit scary, a little bit interesting to find out what people like about us and what we need to do better. But that's going to be done by the ACO with, after getting access to our patient information. The participation in care coordination is really a key thing here that we will be doing, and I want to talk about that a little bit further. There's several parts to care coordination. Transition care, reaching out to the patients who have left the hospital or the skilled nursing facility or the rehab facility, is being done at the level of each practice. The practice has staff that will be and is already calling patients to make sure they understand their medications, make sure they have the appropriate follow-up plans, and that they understand how to support themselves in caring for their illnesses, and hopefully getting them to schedule visits in our offices when appropriate. The IT folks at Doylestown have set up a platform where we can log these encounters, and we already have been able to run reports to see that 3/4 of these patients are hearing from the primary care doctor offices within 2 days of discharge, and more than half are being seen in our offices, so we're off to a really good start with that. Complex care coordination requires a lot more time and expertise, and the DVACO has hired a full-time nurse in order to coordinate the patients. Or these 9,000 Medicare patients need a lot of help. There's a lot of them, and some of them need more help than others. So trying to figure out where the patients that need the most assistance are is a difficult undertaking. It's been done in many ways in different places, and our IT wizards at Doylestown have created an amazing tool to help us find out who needs most. The population health dashboard is something I want to talk about a little bit, because this is really an amazing thing. Not only the Meditech data from our hospital, but also outpatient data from NextGen, Prima, and other EHRs will be coming into this, and it's actually already being piloted. We're hoping as we go forward to get information from Pine Run, from visiting nurses, from pharmacy databases, to get an update on a daily basis of information about admissions, discharges, transfers, medication lists, diagnoses, appointments, claims data, all coming into a SQL database, and then running through a set of scoring calculations that's going to help tell us who really out there needs our assistance. So this scoring paradigm includes points for hospital stays and skilled nursing stays in the last 12 months, ER visits, the LACE scoring, which all of our inpatients are getting scored on now, which includes the length of stay, acuity of care, comorbidities, also the number of medicines people have on their med list, different age brackets, diagnoses like dementia or having had a fall will get you 10 points on this list. Other chronic illnesses like heart failure, coronary disease, COPD, and diabetes give you a few extra points. And what we end up with is a dashboard that ranks the patient according to this scoring, and it really lets us know who out there needs our help. We can look at this by individual practices. We can sort it by payer, so we really can look at in these different contracts we're now responsible for who needs the outreach. It lets us know just by looking at how old the patient is, when they were last in the hospital or the emergency room or our offices. It puts bullets where the certain chronic diseases are. This is going to be a really helpful tool. I've presented this at the ACO, and people are really excited about what we're doing here. This is new and inventive, and really is the kind of ingenuity that I think is going to help us move forward. So the ACO contract is really serving as an impetus, and it's going to allow us to make the changes we need to make in our practices in order to design a system of care to move us forward in value-based contracting for all the patients. We're starting with Medicare ACO, but we're going a lot further.